All right, everybody. Happy Friday morning. Thanks for getting up early and joining us this morning. I'm Rebecca Katz, and I'm delighted to welcome you to the first seminar series for the Center for Global Health Science and Security of the academic year, which we co-run with the Global Health Initiative here at Georgetown. Following the West Africa Ebola outbreak in 2014, and not really even following, but during and immediately after, there was a need to quickly improve the public health infrastructure, and in particular systems building emerges immediate requirements. So we were very fortunate to have been asked by CDC to be implementers for them in Guinea, and working on a series of public health infrastructure capacity building projects, both during and following the Ebola outbreak. We're very privileged this morning to be joined by Mrs. Binta Valder, who has been working with us along with Dr. Alpha-Berry in Conakry for the last several years. So she's been our person on the ground in Conakry, and we've just actually closed the office, but delighted to have her join us here at Georgetown for the week and to have her physically here today. Dr. Berry, unfortunately, was not able to join us, had a little bit of trouble with visas, but we will be representing his work this morning, and also very thankful for his efforts over the last few years and the coordination with Georgetown. So we will also hear this morning from Claire Stanley, who I'm pointing to the computer because she's in Germany, and will be zooming in and providing a bit. She's been the technical lead for our work in Guinea, and will provide a little bit of an introduction and also help present Dr. Berry's remarks. And then we'll also be joined by Aurelia and Erin, so Dr. Erin Sorrell and Aurelia, I always butcher her last name, Attal-Juncqua. That's fine. There you go, close enough. Who are with our center here at Georgetown and have been major contributors to this project and helping to, we hope, contribute to to CDC as well as to the government of Guinea and to the population itself. So with that, let me hand over, I think, to Claire.
Yes.
So, please.
Great. Can everyone hear me okay?
Yep.
Yeah. I can't see you, I'm afraid, so please shout at Matt if you have any questions or want me to stop and clarify any points, and he can be my interlocutor for today. So, Matt, if you wouldn't mind moving on to the second slide, please. Sure. Rebecca's already covered some of this background. Just to reiterate again, as many of you, I'm sure, are already very familiar with, the Ebola outbreak in West Africa was unprecedented in scale, scope, and geography. There had never been Ebola in this part of the world before, or at least not in humans. And cases spread really quickly, causing what eventually was declared to be a public health emergency of international concern. Improving what were perceived as weak health systems across all three countries, particularly in terms of health services, laboratory systems, and surveillance infrastructure, quickly emerged as priority activities within the scope of both the response and longer-term developmental recovery. And as Rebecca mentioned, we were fortunate enough in 2015 to receive a cooperative agreement from the U.S. Centers for Disease Control and Prevention, the CDC, to help provide support to the Guinean government and specifically to the Ministry of Health to support health system strengthening activities in Guinea. And as Rebecca noted, it's particularly important to say that we started our activities during the Ebola response itself. I don't think anyone expected it to carry on quite so long. But when we first started our activities in April 2015, the response in Guinea was still very much underway. And so that provided quite an interesting context for us to begin our capacity building work and navigating that transition period from response to recovery. So given this very dynamic situation on the ground, our priorities changed rapidly, particularly during that first year of work, and also covered a large scope of different technical areas. So across the first year, we actually did engage in some activities related to prevent zoonotic diseases, which Erin will talk about in a few moments, to the detect pillar under the global health security agenda. We did a little bit of work on active surveillance protocols in the initial months, and contributed a bit to some workforce development, but really our main focus was on laboratories, which I'll cover shortly. Excuse me, and then also throughout the 3 years of our work with respect to building emergency management capacities under the response pillar of the global health security agenda. So it really stands for me to say before I move on to the lab things. Oh, sorry, are you on the first slide? My bad. Sorry, slide 3, please. Thank you. Before moving on to the lab work, I just want to reiterate what Rebecca already mentioned, that this was a huge team effort. So not only really want to call out the contributions that Ms. Bint had provided in being our program manager on the ground, and of course Dr. Barry's invaluable contributions in our country office as well. I think pretty much everyone at the Center of Global Health, Science and Security at some point has had a role within the Guinea project. We've all been contributing. There were a number of past employees also who contributed to this effort, and a number of consultants. I don't know if Ellen Carlin's in the room, but she's someone who provided us a lot of support right at the beginning, so
she is.
Big shout out to her. And of course, a number of different partners in country, so both fellow implementing partners from CDC, some of whom we'll mention over the course of the following slides, and then especially the Ministry of Health. They were our primary partner within the government of Guinea, and really we could not have done anything that we accomplished without their explicit support and particularly their attention given all of the challenging competing priorities that they faced also on the ground, especially in those early months of the response. Okay, so next slide, please. So just to talk a little bit about some of our laboratory work, and again, I'm presenting this on behalf of Dr. Barry, who unfortunately couldn't be with us today. And connectivity being what it is in Guinea, it was difficult for him to join via Zoom as well, but I'm still hoping that he will join at some point and be able to listen in. During the Ebola outbreak itself, specimen referral was identified as a major gap. There had been some systems in place for vertical disease control programs, notably for vaccine-preventable diseases in Guinea, where, for example, polio specimen suspect cases of polio would have specimens sent directly from the peripheral health system to the national level. But it was very disease-specific. They all happened in parallel, and they were dependent on project funding. During the Ebola response, a new ad hoc system was established for getting Ebola specimens as quickly as possible from the local level to the specialized mobile and other laboratories that were set up for Ebola diagnostics. So the Ministry of Health recognized that as the response came to an end and was transitioning towards recovery efforts, there was really an opportunity to build on some of these structures that had been put in place during the response and create more of a national holistic system for transporting all types of priority disease specimens. And they asked us, given our policy experience, to work with them to develop a national policy for specimen referral. Slide 5, please. So this actually was a collaborative project with IMC, the International Medical Corps. I don't know if Ashley's there, no, but that was something that we set with them. And the idea was that Georgetown would work with the Ministry of Health to develop the outlines of a national specimen referral policy, and IMC would do a pilot implementation project in a few select areas of the country to make sure that the policy recommendations we were putting forward actually worked in practice. We wanted to make sure that this was going to be a system that was applicable to the Ghanaian context, that was usable and that feasible, and most importantly, perhaps sustainable over the long term. So it was not a quick process. We wanted to make sure that we got input from as many stakeholders as possible. This involved lots of different meetings, workshops, Ms. Binta chasing people up over weeks and months to provide their input on drafts. But finally, after a number of months, the policy was finalized and validated by the Minister of Health and is now officially in practice in Guinea. So that, I think, represents really an important accomplishment collaboratively between our team and the Ministry of Health for building an important piece of the laboratory system. Next slide, please, Matt. So, of course, once policy is in place, it has to be implemented, and that proved to be another challenge in itself. Guinea has quite a decentralized system of health pyramid, as they call it, with a large emphasis now being placed on health system strengthening at the peripheral level of the system. So we need to make sure that all of these different levels were aware of the specimen referral policy and understood their roles and responsibilities for collecting, managing, handling, and transporting specimens to the appropriate facility for further diagnostic testing. Again, all within the context of making sure that there is rapid and early detection of priority diseases under surveillance. So this part of the project was actually performed largely in collaboration with a bigger effort to update and revise Guinea's Integrated Disease Surveillance and Response, IDSR guidelines. Again, within the broader sense of global health security and the international health regulations. So we work closely with the surveillance teams within the Ministry of Health, CDC, and other implementing partners, including RTI International, to identify the priority diseases that would need to be included in this effort, and then to develop standard operating procedures, job aids, and referral decision algorithms to support the operational work of laboratory technicians and clinicians from the very lowest levels of the health system all the way up to the national level to improve this process of diagnostic testing. So to date, these SOPs and job aids have been disseminated to all prefectural laboratories in the country. That's 34 different prefectures covering the entire territory of Guinea. We've had a training of trainers workshop for the prefectural laboratory workers so that they understand how to use the SOPs and job aids in their daily activities, and with the idea that they can then pass on their knowledge to their colleagues in the laboratories at the local level. And improve the systems that are in place there. So this is still, it's going to take more effort. It's still kind of a work in progress, but we think we've made big strides and really hope to see this continue in the future as well. So that's it from me on lab, I think. So handing over to Aurelia, I guess, for emergency response operations.
Sure. No, it's okay. I can sit. So Matt, can you put the next slide on? Thanks. Oh, next slide. Great. So as Claire noted earlier, we also supported Guinea's emergency response operations. So the first thing we did, the team partnered with IOM, so the International Organization for Migration, and undertook an evaluation of the systems and staff needs at the prefectural. Can everyone hear me? No? Okay, sorry. Maybe I'll stand up.
No, that's what.
Yeah. So as Karen noted earlier, we also supported Guinea's emergency response operations. So the first thing that the team did is they went to Guinea and partnered with the International Organization for Migration, IOM, to undertake a needs and systems assessments at the prefectural level for the emergency operations centers there. So these are the subnational EOCs. And following that, we drafted a training curriculum for public health emergency management. Which also included a trainers workshop and module that was rolled out across the different prefectures in Guinea. We also did some different sort of support and aid. For example, we provided technical input to support the National Emergency Operations Center in the drafting of key documents, like the concept of operations, the National Emergency Response Plan, and other standard operating procedures that are all crucial for the operationalization of the EOC. And later on, we also created a bunch of tools and resources to support the EOC at the national level. So, for example, we created a guidelines and best practice document to help them draft a national multi-hazard national preparedness plan, as well as tools and resources for risk communication, both with the media and the public, but also with for internal purposes, so like internal coordination during an emergency and after an emergency. And this project was a bit longer and the most recent one. So to give you more context about this, in 2016, right at the end of the Ebola outbreak, the president of Guinea, Mr. Alpha Condé, established a brand new health security agency in Guinea called the ANSS. It's the French acronym for National Health Security Agency. And this brand new agency really capitalized on the past lessons learned from the Ebola epidemic. However, because it's brand new, to be fully effective, it really had to, its authorities, and when I mean authorities, I mean like its legal authorities, really had to be well defined, especially in the context of like the larger government. It had to be well defined compared to the other agencies and ministries that may be involved in public health emergency response or preparedness. So, and actually, a well-defined legislative framework is a key requirement under the IHR, the International Health Regulations, and also a key area in the JE, the Joint External Evaluations that's led by WHO. So what the team did to help the ANSS with that specific problem is that we undertook a legislative landscape assessment of the whole government, looking at every legal document or regulatory document that supports emergency management activities in all the ministries and agencies. And after that, we went back to Guinea and organized a workshop where key legal experts from the different ministries and key technical experts from different ministries gathered together and kind of analyzed all the different authorities that exist through a outbreak scenario-based discussion. And that allowed us and as a group to identify the key gaps and overlap that exists between the different laws and policies as well as in the different ministries. So for example, looking at responding to a outbreak coming from a zoonotic source, how do the ministry collaborate and what are the authorities that support each activity for each of the actors? And following this, we were able to provide a pretty long list of recommendations to actually help Guinea strengthen its initiative system when it comes to outbreak management and public health emergency management as a whole. And we're hoping that we can continue to provide support, even if it's remotely, to help them further this effort. That's really important. It's for you, Erin.
So last but not least, I'm going to talk a little bit about some of the work that we did for zoonotic diseases, and we really tried to make this a One Health systems assessment. So we not only included traditional ministries of health and agriculture, but also of environment. So our objective for this project was really to look at a One Health approach to evaluate Guinea's systems for prevention, detection, and response to zoonotic diseases, as it was outlined in IHR and later through JEE. And this is a project that was one of the first projects we did in Guinea. As Claire mentioned, we have Dr. Ellen Carlin here today from EcoHealth Alliance, who was instrumental in this project as a consultant with our team. And of course, Ms. Binta, we could not have done this work without you. So thank you both so much for being here. What we tried to do was look at a system-based approach to look at how we can map zoonotic diseases. And this was a process that we developed in 2013, 2014, and trialed it out with Jordan, Egypt, and Algeria. So we had some experience working with this system when it came to Guinea. And our first step was really looking at what are the key stakeholders in the host country. Depending on the country, various ministries can be involved, whether it's through public health, livestock health, wildlife would be a key issue, obviously, in Guinea. And we noticed that we needed to have both health, livestock, and environment included in our analysis. The next step was to really, with those three key ministries and other various stakeholders, look at what are the priority diseases, both weighting from a public health and a zoonotic and veterinary health perspective. What are the diseases that are endemic? What are the diseases that are going to cause substantial human morbidity and mortality, as well as burdens on animal populations? what are pathogens of international concern, both WHO and OIE priority diseases, and then what animal hosts exist in Guinea, both wildlife and livestock and domestic animal species. So once we looked at, and this was again a very collaborative process that did not just take 5 minutes, there was lots of discussion about how we would prioritize diseases. We wanted to make it realistic and important for all sectors involved. So we defined and assessed the current surveillance and laboratory systems. So what we wanted to do was really map the nodes of communication and coordination between both public health, veterinary health, wildlife sectors from the point of case detection all the way to laboratory confirmation, diagnosis, and reporting out and response. So that was quite an iterative process with all the stakeholders to look at, for each of the priority diseases, what systems are in place in Guinea and where are the major gaps so that we could identify potentially either specific disease programs that were effective or if there are general gaps across many priority diseases. So we looked at identifying current information exchange pathways, as I mentioned, and then evaluating the strengths and the weaknesses. So pulling together an assessment, mapping out for each priority disease what systems were in place, and then with our stakeholders really identifying where the key areas for improvement, where the major gaps are to strengthen. And so that was really our key efforts in this One Health mapping. Matt, next slide, please. So what we were able to come up with after various discussions across the different stakeholders were 6 priority diseases. They were rabies, brucellosis, anthrax, avian influenza with a priority on high-path avian influenza, trypanosomiasis, and viral hemorrhagic fevers. And it was, of course, during the Ebola outbreak and response that we were having these conversations, and of course Ebola was in the front of everyone's mind, but it was important to us to really lump viral hemorrhagic fevers together because Guinea as a country have more than just one viral hemorrhagic fever to focus on and consider when we think about zoonotic disease transmission. So we wanted to make that a grouping versus focusing on a specific virus itself. We identified as a group 5 major areas for future capacity building. So this was based on our ability to map both disease-specific systems as well as the overall system. 5 areas for capacity building. The first is collaboration and coordination. This is both within ministries and then across ministries. Training and personnel, both from surveillance and laboratory systems. The infrastructure, not only for sample collection, as Claire mentioned with the National Specimen Referral Policy, but also for laboratory capacity. Public awareness, thinking about community involvement, both in terms of livestock health, but also in terms of access to community centers, health clinics for reporting and seeking treatment for potential zoonotic diseases. And then research, so priority research focusing on the 6 diseases that we identified as a team. So the outcomes from this project, and again, this was one of the first projects that we did as a team in country. We had a formal report that we shared with all 3 ministries, and it was a very collaborative process as we wrote the report to show not only what works and the strengths, but what are the current gaps or the weaknesses, and delivered that to the different ministries for feedback, and then also to help with priority setting for zoonotic diseases moving forward. Because of the information that we got while we were doing mapping specifically for rabies, and because it was a priority, a very strong priority across all 3 ministries, we actually ended up doing a standalone report specifically for rabies, which went much more in depth to look at renewing national efforts to control rabies in Guinea. And one of the really wonderful outcomes of that work was that we were able to, for the first time ever, support ministry officials to attend a regional conference on rabies surveillance and rabies livestock, from the Ministry of Health and the Ministry of Livestock for a regional rabies conference where they were able to present some of the work. And so we were really thrilled to be able to support that. national capacity. In 2016, we were lucky enough to be able to transition our efforts to incoming USAID funding for preparedness and response. And this has really, I think, just carried through the work both in One Health and Zoonotic Diseases, and we're lucky to have Kendra here today. Thank you for coming. And thank you. Hi, how are you? So we've got lots of partners here. It's wonderful. And we were thrilled to be able to have started that initial work. And because priorities for CDC had changed, USAID and other partners were able to pick up that work and continue it going. And we were happy that our report was able to inform some of the initial work that was identified moving forward. Next slide, please. And that, I think, wraps up at least the presentation portion of the talk. But again, I think we still have Claire online, and so we're happy to take any questions, either specific project questions or just in general on our work in Guinea. But thank you all so much for coming at such an early hour.
And also, I think most of our reports are actually on the website,
Yes.
on our website. If you want to read in more details what we actually did, it's all on the website.
Yeah, and I'm standing here with my computer because I'm actually I'm messaging with Claire as we speak. She's coming up with the thing. Don't forget to say. I mean, the idea was to wrap up the actual formal presentations kind of early this morning because we wanted to have an opportunity to talk with all of you, to answer any questions you might have. This was we're a research team. We are not we have not had a lot of experience as implementers. So this was kind of a unique experience for us, and we are actually, as Erin mentioned, our work in Guinea is wrapping up over the next couple of months, and we're very fortunate to be able to try to transition some of the work we've been doing to other agencies, to other implementers, and we'd really just like the opportunity to talk with you a little bit. So if you have any questions. We're all here to help answer them, and Claire can hear us, and if she can't, we'll type it out for her. So please, if anybody has questions.
Rich? You had mentioned the ministries of livestock. How does that fit into the overall structure of public health? Is that part of public health responsibilities? And so do you have the leadership of public health is participating in this, not just the ministries?
So, Dr. Claire, can you hear me if I speak loudly?
Yeah, I can hear you.
Okay, so Dr. Calderon asked for the work that we were doing where we had multi-sectoral collaboration, how did that fit under did public health have, and correct me if I'm misquoting you, public health have the lead, or how did we organize and prioritize public health priorities, for lack of a better word choice? Yes, okay. So particularly for, and I'll turn to Aurelia for the EM work, but particularly for the One Health work, it was crucial for us to get all three ministries to buy in. So before we really did any of the stakeholder mapping, before we did any of the workshops, we socialized the projects. We had support from the Ministry of Health as our key interlocutor to the government of Guinea for the work on zoonotic diseases, but it was crucial for us to also have buy-in from Ministry of Environment and Ministry of Livestock. So Ms. Binta actually helped us quite a bit in terms of socializing the projects and getting buy-in from each ministry, because without that, I don't think that we would have had the impact in terms of being able to not only talk to the people we spoke to, and but to have the support from the ministries for disease prioritization.
The second part of it is, so the public health at maybe the end of the outbreak was at its strongest point, I think. and so can you assess where that is now, the general feelings about public health there versus what it was at its best support?
Sure, and I might actually let Claire take this one. Claire, the question was, at the end of the outbreak, Ministry of Health was essentially at its strongest from the point of the first outbreak the point of the first case of Ebola to kind of the wrapping up and declaration that the outbreak was over. And so what your question specifically is.
So what is your assessment if you have that kind of information about then versus what it is now?
So Claire, what is your assessment on the overall capacity building and the experience that MOH had during the outbreak that made them stronger? And are they still happening today?
That's a great question. And I think that there's a number of people in the room who could actually answer that probably better than I could. Certainly would love to hear from Kendra and maybe Sambe as well in terms of your thoughts too. One of the things I think we can contribute, maybe not quite quantitatively, but certainly progressively, the fact that we did our One Health assessment so close to the beginning of the end of the outbreak, as it were. So starting in early 2015 and then kind of finishing in early 2016 is when you look now at some of the gaps and recommendations that we made then, they've already been addressed. And so as Erin mentioned, the USAID supported preparedness and response project has filled a lot of those gaps. Other efforts under surveillance, laboratory capacity building, and workforce development, particularly CDC's field epidemiology training program, which has started to be implemented in Guinea as a short course in-service training. These have all really made huge strides. So I think the basic answer is yes, there has been a lot of progress made. I think it's going to be challenging to see what happens next. We are not the only implementers who are slowly phasing out our work in Guinea. A lot of the US appropriation for Ebola is coming to an end. And it's going to be very interesting to see what happens in the next, say, 3 to 5 years in terms of trying to sustain some of the gains that are there. Of course, there's other partners who are working. The EU has provided a lot of funding in Guinea. The World Bank has a very large multi-sectoral, multi-million-dollar project called Radice, that covers laboratory surveillance, emergency operations, and workforce. But it is going to be a challenge. And I think that there is a really big opportunity for continued U.S. leadership in this area, and I really hope that this isn't the end of the actions that we've taken already in country.
And to answer the first part of your question about how the other ministries are involved in public health response, shortly after Georgetown did the One Health assessment, Guinea started putting in place this new platform called the One Health platform that was actually formalized and signed off, I think, in 2017. And that platform includes representatives from the Ministry of Health, of Livestock, of the Environment, and others that I forget now. And they all meet on a regular basis, and they all, at least I think one rep from that platform comes to the weekly outbreak or EPI meeting that they have. So there is much more collaboration now, and it's much more unified than it was before.
I'm Sandy Joy. I'm the One Health Advisor for the Preparedness Response Project of the USAID. As you see, one of the first recommendations that came out of the work was coordination and collaboration. And it happened that it was the time we were getting to Guinea to also try to promote coordination and collaboration. And we have set up a One Health coordination platform. And the chair is from the Minister of Health, and the vice chair is from the Minister of Livestock. And the vice chair is one of the very active person of promoting multi-sector collaboration. And if you look, getting into the second part of the question, if you look at when the Ebola outbreak started, it means that the public health system was really weak. But they learned lesson from that system, and now you have Guinea expert now in Congo helping with the Ebola outbreak. So there is some improvement. We not say that if it's Ebola today in Guinea, they will completely master it, but they will do it better than the first time. So there is some improvement in terms of the public health system, both in the laboratory system and also in terms of training human resource.
Just to add to Sambe's points really quickly, I think the parallel there with the outbreak in Democratic Republic of Congo is particularly illuminating because during the outbreak in Guinea, there were a large number of experts in Ebola from the DRC who came to Guinea to support the response. And now Guinea is able to have the capacity to return that favor and support the response in Congo, as Sambe mentioned. So I think not only does it show the great strides that have been made in Guinea in terms of capacity building, but also the extent to which this has encouraged regional collaboration and the development of regional capacities for preparedness, detection, and response, which I think are going to be critical in the future.
And I think just building upon, I wanted to address your point about Guinea being at their best point, the Ministry of Health after the outbreak. That actually wasn't the case. You know, you have to remember the health system collapsed under Ebola. Some areas, like the forest region, they had a 90% decrease in testing for malaria. We saw malaria rates peak. We saw acute respiratory infections, diarrhea, and so I agree with everyone. We are in a much better place now, but that would not have happened after the emergency without having funds for recovery and for global health security. And so we are now in a much better place years later. But for USAID, we had what we called our Pillar 2, health system recovery and strengthening, and that's just ending. So that was a multi-year effort to literally pick up the services, get the clinics to build back better, but they were actually in a worse state than they were, prior to that, and they were already in a very weak state. In terms of the response, a lot had been gained, but a lot of the labs were run by the Congolese, DRC expats, and so after the emergency, despite having gotten through the emergency, it was based on a lot of international staff dealing with the emergency, and so I think that part and that piece is really important because the way we look at other emergencies, particularly in very poor and developing countries, if we didn't have those additional resources beyond just getting funds to cover the emergency, we wouldn't have left Guinea in a much better place. They would have had a lot of mobile labs that are not being used. You'd have a lot of workforce that's not trained. We'd have a lot of services that were still quite diminished. So I think...
No, I believe all that. Yeah, I do. It just, for me, it's what happens. So if you have a cluster of brucellosis or something, then what? What is the response to that?
And that again has been a big multi-sector approach, I think, which has been great. I think on the side we've had a lot of partners on human health, including CDC and the partners in WHO, strengthening the IDSR system. For USAID, we've put a lot of resources into the animal health because being able to address those diseases early on. So the central vet lab wasn't functional. We had to restore the electricity and the water and the training and provide workforce. So we are in a better place. And actually for brucellosis, we just completed a surveillance in the animal sector through FAO. And we're working on getting the diagnostic.
Can I ask one?
Sure.
So I know in the case of MERS, the government there made the decision about who got the specimens. Did it go to the U.S.? Did it go to Paris? Did it go, and is that not a problem with this kind of thing which is going on?
About where
the
government decides.
Where is it going to be done?
Yeah.
And who is entitled to the specimens, who's not entitled?
Yeah, absolutely. I mean, I think that's part of strengthening the country's ability to deal with IHR issues effectively and to strengthen those regional partnerships and that transparency and to work on strategies so that you have a plan in place.
So that's been pretty settled.
I would say it's completely settled. It's a work in progress, and I think as they get stronger and stronger, strengthening IHR system.
And I think as Kendra mentioned in the beginning, there was no lab capacity to do any type of diagnostics. Exactly. And so when we think about a lot of the partner countries, both the US, France, I believe Russia, had labs, either they built up capacities in existing labs or provided mobile labs to help with the immediate response. And those labs have actually gone through a transition and been handed over to the government of Guinea, which has just shown, as Kendra mentioned, if we had only had 1 year funding, those types of processes, both from a U.S. government and other partner governments, would have never worked. So having a multi-year process where we could actually not only prioritize what are the actions needed immediately, but long-term response and recovery were crucial, I think, to building up capacity not only for surveillance of priority diseases like brucellosis, but then having the lab systems in place to actually detect suspect cases. And that is now, run, and then most, I know at least with the lab that was provided by DITRA, the Defense Threat Reduction Agency, is run by Ghanaians. with some assistance from Ginger, but it is a Ghanaian lab now.
I actually have a Detroit colleague. Well, she's for
Hi.
good
I work for
there.
MRI Global, but
Wonderful.
we actually were there in the beginning when we put the lab in place and moved it. I've been training ever since. So.
Great.
Thank you.
One thing I wanted to add to the comment about the sample sharing, and this builds upon a forum that was hosted here with the law school as well about MTAs. There was a lot of sensitivity after the outbreak in all three of the countries about what happened to the samples during the outbreak. And I think countries like Guinea, Sierra Leone, and Liberia that don't have research capacity and haven't had a lot of partnerships, they didn't have MTAs, they didn't have a say over what happened with the samples. And following the outbreak, I think they felt that a lot of countries came in and just took the samples that they wanted. They went to Russia, they went to China, they went to the UK. There was no accountability. So after the outbreak, there was a lot of sensitivity, and it has been a large work in progress to sort of restore that confidence in the international community that, we'll respect the country's rights to help make those decisions.
That's a very positive thing.
Yeah.
Take us on him.
Yeah, so where did bushmeat consumption or wild game consumption fall in your research and in your efforts, and then the shared maybe food source between wild animals and human beings as far as what you were doing for prevention?
Great question. I feel like I've been talking forever. So Ellen, do you want to, would you want to kind of respond to that?
I'm not going to give that a try, or I don't know if we still have Claire. So I'm Ellen, and I helped with the One Health Zoonotic Disease Capacity Assessment. And is your question related to that specific process?
Well, I've heard a lot of talk about livestock, so I just was wondering about the food sources that aren't livestock that people, especially protein sources like wild game, so whether or not that was part of where those efforts fell, and even in ministries, and then how you looked at that, where that progress went.
Yeah, I mean, from what I recall from the workshops that we had, and I don't know if you remember, but I don't think bushmeat or wild game as a point source of potential infection was addressed specifically. I think that, when we were working with the partners, we were asking them, what are your priorities for infectious diseases? And most of the ones that came up really were sort of irrespective, I think, of food sources, whether it was, anthrax, I guess, might be a different case because anthrax can be transmitted through consumption of contaminated meat. But I think that when we addressed the system as a whole, it was kind of irrespective of food sources. And Claire, I don't know if you have anything to add on that.
Yeah, I mean, I think so. When we were doing the assessments, we were really looking at the capacities in place to detect and then respond to the various priority diseases. So, in the case of bushmeat specifically, as Ellen mentioned, we were looking more at the different study diseases first. Of course, there's relevance there, as she mentioned, for anthrax or hemorrhagic fevers. But the entire Ebola outbreak in West Africa, all 28,000 cases and 11,000 deaths came from a single spillover event. So in the grand scheme of the whole outbreak, that aspect of it was compared to the importance of, say, contact tracing and rapid diagnosis and getting rapid response teams in place was perhaps less of a priority at that particular point in time. It's also worth noting there were a number of other efforts ongoing in Guinea, both at the time we were working and afterwards, that looked much more closely at the issue of bushmeat, knowledges, attitudes, and perceptions of local people towards bushmeat and other potential sources of infection, both for viral hemorrhagic fevers and other types of zoonotic diseases. Some of that involved anthropologists, others looking directly at circulating pathogens, for example, through USAID's PREDICT project. So while we didn't focus on that aspect within the context of our much more systems-related assessment, there were certainly people who were taking that into consideration. I hope that answers the question. I wasn't sure exactly what others had said.
Hi everyone, my name is Emmanuel from RTI International, and I just wanted to ask a general question about your collective experience handling, working with partners in these countries during the outbreak. Were there any community-driven solutions within the three countries that were hardest hit that served, teachable moments, things that we can use for future outbreaks? in sub-Saharan Africa and other similar settings where there are, community-driven approaches peculiar to either Liberia, Sierra Leone, or any of the other countries that, we are taking away from this as a template for the future.
Do you mind if I just repeat it for Claire? And I believe we have Dr. Barry on the line as well. So the question was, are there any, and it might, if it's okay, we might answer in respect to Guinea just because that is really where we worked. Were there any community-driven initiatives that helped not only promote our work in Guinea, but also any lessons learned for how those initiatives help to strengthen the response and recovery? Is that a lot to help strengthen the response and the recovery to the outbreak? Anything that we can take away as lessons learned from a community-based intervention approach? So I don't know if we want to ask Dr. Barry for his input since he hasn't had a chance to speak yet, and we have him on the line. If he can hear us. Or Claire, or I'm happy to address her.
Yeah, sure. So I'll just say a few things and then we can pass it over to Dr. Barry as well. So, first of all, I think it's worth emphasizing that our work specifically was much more from the top-down policy level. We tended to focus our collaboration with the Central Ministry of Health, although we did, of course, to an extent work with people at the periphery in terms of understanding the needs and expectations of what the national level policies and practices would look like when implemented at their level. So, our work didn't directly address community-based surveillance or community-driven efforts. It may not actually be the best group to talk to about lessons learned there. We did collaborate with a number of organizations who did a lot of work at more of a grassroots level. Arter International, in fact, was very implicated in instilling community-based surveillance efforts in a number of places. And I mentioned earlier our partners, IMC, who did the pilot implementation project. More anecdotally, just in terms of efforts that I'm aware of, I think there was a really strong push to make sure that the people who are engaged in contact tracing and local level notification of disease were people from the community. There was a lot of distrust in the national health system, particularly in more remote areas at the beginning of the outbreak, and that did not improve during the outbreak. And so there was an acknowledgement that community engagement was going to be critical to maintaining progress towards interrupting transmission and ending the outbreak. And I think that's something that has been transitioned quite successfully into Guinea's overall health strategy now, with a very large emphasis on community-based surveillance and empowering local communities to be more involved in disease identification and notification. Dr. Barry, I don't know if you want to say anything about community efforts in Guinea now for disease surveillance?
All right. Donc, pour les engagements communautaires en Guinée, ça a été un des points faibles du système lorsque Ebola est venu en Guinée. Pourquoi? Parce que tous les partenaires, y compris le ministère de la Santé, les spécialistes en communication, se sont décidés de rester dans les bureaux et développer des approches de communication au niveau pour la prévention de l'Ebola et oubliant d'inclure les communautés à la base. Donc, on vient au niveau des communautés avec nos stratégies et puis on essaie de les imposer et ils n'étaient pas d'accord. C'est ce qui fait qu'il y a eu beaucoup de réticences et ce qui fait que les gens n'étaient pas du tout d'accord qu'on vienne là-bas. Et c'est ce qui a justifié auprès des communautés que c'est les Blancs qui amènent Ebola en Guinée. Parce qu'ils ne sont pas associés dans le développement, dans l'identification des problèmes, dans la gestion des problèmes, et y compris dans la gestion de l'épidémie Ebola. Donc ça a été un point faible. Et maintenant, on s'est rendu compte de cela à un certain moment où c'était presque très tard, où le Comité national de lutte contre Ebola, l'OMS, l'UNICEF et tous les partenaires du développement, y compris le CDC, l'USAID, ont tout de suite dit qu'il faut appeler les anthropologues allez parler avec les communautés pour les impliquer dans le cadre de la lutte contre Ebola. Et en chef de file, mettre les leaders communautaires devant, les leaders religieux devant, les thérapeutes devant, et les jeunes qui étaient là, les femmes en association aussi. Donc c'est ce qui nous a permis de gérer rapidement les réticences communautaires et qui nous a permis d'augmenter leur niveau d'information et leur niveau d'acceptation des approches et des comportements que nous leur avons demandé de faire.
Merci, Dr. Barry. Claire, I can translate quickly if you like.
Sure, go for it.
Right.
Thanks.
So I'll try and summarize all of this. Basically, what he said is that at the very beginning of the outbreak, the communities were not involved in risk communication, and that was a big issue because it meant that the people who were doing all the risk communication work were basically doing it internally and thinking that they would reach the communities, but it didn't. And that resulted in like more distrust for the government, more distrust for the Westerners coming to help, and that created issues at the beginning of the outbreak. At some point, obviously, things changed. People realized you had to involve the different communities, and that helped. So people started to involve the women's group in villages, as well as religious groups in the villages. So the religious leaders of each village took a more active role in communicating the risks. They also partnered with UNICEF and other international partners to involve young people, like the Scouts of Guinea, I think, were involved at some point. And that really helped kind of mend the trust. People saw, like, the people they knew, the women of the village, the religious leader that they knew, the young kids that they knew, come to their door and actually tell them what to do and not to do to avoid transmission. And that's a really big lesson learned, and I think Guinea knows to do that now, and that's something that other countries also do and already did before. That's it. Any other questions? Yeah.
Yeah, Bob Sorensen with NIH. I wonder if you can expand a little bit. You said you were working on building research capacity. That's a very large area, and if you can give a little detail on where you're going with that. I mean, obviously you can't build the whole academic and medical, research community, but that's really what's needed in the end.
Yeah, that's a great question. So, Claire, please feel free to hop in. I will preface it with saying that our cooperative agreement was not research focused. So it was very much implementation and addressing the needs during what we initially had hoped would be the response, recovery, but was really for many years, or at least for the first portion, the response to the outbreak. I do think, though, however, that a lot of the work that we did highlighted opportunities for collaborative research, both between organizations in the region and then in Guinea itself. Some of the laboratories that we visited for mapping, for specimen referral policies, identified laboratories that had capabilities for basic research for priority diseases. Some of the veterinary schools in the country, and I think Guinea was unique in the sense that the veterinary capacity in Guinea was stronger than in some of the other countries that faced the outbreak. There were capacities, they just needed to be uplifted and kind of rejuvenated. And I think that our work highlighted where those capacities could be met. But unfortunately, we did not have the funds or the types of funds that allowed for basic research. But I think we tried as much as we could to highlight where those opportunities were. Claire, I don't know if you have anything else to add to that?
No, I think that you largely, certainly there's a huge need to build research capacity and a huge interest. One of the challenges we identified actually during the One Health assessment was that in the past there has been a fair amount of research done, particularly in terms of looking at priority disease surveillance and prevalence, both on the side of the livestock and wildlife sectors as well as in human health. But a lot of these reports are kept as hard copies in a university somewhere and just never disseminated. So one thing that we think actually would be a very easy step to start thinking about building research capacity is to digitize some of what has already been done and really understand the baseline of knowledge is from which to build and develop more priorities. Of course, NIH and IAID and others are actively working to build research capacity at some of the institutions in Guinea. In 2017, an Institut Pasteur was formally established in Guinea as well, which is going to become, I think, a leading center for research, and it's under the auspices of the Ministry of Higher Education and Scientific Research, which means that it really is a local institution and can serve to develop local capacity that way. But as Erin said, this wasn't, unfortunately, it wasn't a focus of our particular project for the last 3 years, but something we're very, very interested in. And so certainly would want to explore opportunities for doing more in that arena in the future.
And I would add, this was a cooperative agreement, and for anybody who's ever had a cooperative agreement, they change over time. And we had identified very early on the importance of, I think, as Claire mentioned, of just getting research that is already happening out to the rest of the community. So the original proposal actually had us doing a journal as well, but as things happen, that fell off as the list of priorities. But I think it's still really important, and it's not just encouraging the more research, but also capturing that which has been done. Ambassador Colbert.
Thanks. I'm Jimmy Colbert, ISP at the Department of Health and Human Services. And one of the challenges is that while health system strengthening and emergency preparedness and response are synergistic and contribute to the strengthening of both, in fact, there's a huge tension in many places between them because there's no excess capacity, and the surge that you would need in an emergency response just isn't available from the kind of human resources that would be available in countries like Guinea. And I wonder if you saw that tension there and how you resolve it, and are there now in place sort of agreements for the surge possibilities with NGOs, international organizations, civil society groups, or others who might be able to make the plan actually implemented?
It's a fantastic question, and I will definitely hand over to Claire, and actually Kendra and Sambe and others in the room, please feel free. I will say my first trip to Guinea, Claire and I and Ms. Binta were at a prefecture level meeting, the surveillance meeting of the day, the DPS meeting before everyone out to do either contact tracing or assisting. And I think there were at least 60 people, room overflowing, probably 5 were Ghanaians. And so it was very eye-opening to see when we did introductions, and mine was awful in French, but Claire helped me out, was who was there, from where, and how long they were staying. So one of the things I think that really helped our team be successful was not only the fact that we had very competent, fluent French-speaking team members and an in-country staff, but that we had a multi-year funded cooperative agreement that allowed us to not only assist with the immediate needs, but to continue on for the what we had hoped in the beginning would be capacity building. So I think that it was tense in the beginning to see who was reporting information back and how that was either getting reported to their home institution versus the Ministry of Health and to the EOC for data collection and for the next day's assessment of what should be done. I think that as the outbreak continued and as both NGOs, foundations, and other government entities and implementers identified how they could best coordinate across each other, it got better. I know, at least for our cooperative agreement with CDC, we had various implementing partners that actually did annual meetings where we reviewed what our initiatives were, and we collaborated as a group so that the CDC cooperative agreement implementers were not duplicating efforts with implementers for USAID, implementers for DOD. So they, at least from a USG perspective, we tried very hard to coordinate implementers on the ground. And based on our areas of focus, we then collaborated with international partners as well. But I would say it was very much an implementer-focused initiative on the ground to coordinate with other partners as you met them in meetings or as you met them on the ground in your projects. Claire, I don't know if you have any information on if there are agreements or MOUs in place on how assistance would be provided in the event of another outbreak in coordination with Ghanaian ministries?
I'm sorry, it's quite difficult to hear you, Erin. Do you mind repeating that?
Sure. So, and this is something, Ambassador Colger, I apologize, I do not know, is what for a future outbreak, does Guinea have identified mechanisms in place to coordinate? Yes. So does Guinea have in place mechanisms to coordinate implementing partners during a surge event, a surge outbreak, surge capacity for either human resources or infrastructure, equipment, etc.?
It might not just be implementing partners, or just assuming government.
Oh, like national.
Yeah.
How would they handle surge?
So how would the government handle surge capacity? Have they discussed that at all? Do we know?
Yeah, yes, absolutely. So that's been a big focus of the Emergency Operations Center and some of the effort to operationalize it. One of those, two pieces of that Aurelia mentioned in her presentation are developing the emergency response plan and the concept of operations. And part of those documents is establishing a system for coordination of international partners and also an approach to how that coordination would take place when a public health emergency is declared by the Ministry of Health. What is less clear so far, but it's certainly something that is being worked on, is the actual implementation mechanisms for making that coordination happen. So I'm not sure, for example, at this point in time, whether plans have been drawn up to facilitate the deployment of medical personnel into Guinea in the event of a future outbreak. But that is definitely something that has been worked into these emergency response plans and is obviously part of the joint external evaluation in terms of the technical area for under response. So something that Guinea is going to be working on.
So I'm being told it's 9 o'clock, and I know some people have to get to class and others to their day jobs. So we'll wrap up here, but we wanted to first thank you all for coming. I'd also love to take yet one more opportunity to thank Dr. Berry for being online and for calling in and for all of his work and Ms. Pinto's work in Guinea and their efforts to really make, we could not have been successful in our efforts without them. And they've been a critical member of the team and again, delighted that we're actually able to have Ms. Pinto here with us in Washington. I think, again, I know folks have to run, but hopefully Claire can stay online. It's not too late in the day for her, and we'll stick around for a little bit if anybody has questions and wants to discuss this more. This is also where I plug our future events. So we have, if anybody's interested, our next seminar will be October 10th. It's actually a Wednesday morning, not a Friday, at 8 a.m. And Billy Karish from Equal Health Alliance will be speaking about One Health. And he is, for those of you who have heard him speak, he is an engaging speaker. So we're delighted to have Billy here. And then in November, November 15th, mid-November, Matt Hepburn, who is at DARPA, will be here talking about some of the work that they are doing on biotechnology and medical countermeasures and the biotech side of addressing global health threats. So with that, again, thank you all for being here, and please join me in thanking